Yeah, welcome to a new podcast during a congress in Switzerland, in Basel. My name is Melvin Bos, physiotherapist, manual therapist and board member of the Dutch Association for Manual Therapy. And today we're recording a podcast with two guest speakers. Before we starting over with the subject, it would be nice to give them a space to introduce themselves. First of all, in front of me, can you tell to the listeners, who are you and where are you from?
I'm Stanley Paris, originally from New Zealand and more recently spent most of my adult life in the United States. I'm a physiotherapist, so was my father before me, and I'm a manual therapist.
Yeah, yes. Nice. Good to hear. And there's another guest speaker on the other side.
Yeah, I'm your colleague, board member of the Dutch Association of Manual Therapy. Happy to see you, and so happy to hear from you everything about the manual therapy history, but also tips for the future.
Ooh. Well, okay, so a little bit on the history, if you wish. I'm one of the four founders of IFOMPT, along with Gregory Grieve of the United Kingdom, Geoffrey Maitland of Australia, and Freddie Carlton-Morn of Norway. We all met in London in 1966 and agreed on setting up a committee, which I was the chair. And then we were to meet, and we did, in Montreal, Canada, in 1974, had a constitutional conference, and founded IFOMPT. I later became the second and third president of IFOMPT, and had 16 years on the executive.
That's pretty nice to hear, Stanley. There was yesterday there was an introduction of IFOMPT and every decade on it with a nice video to watch. What's your experience with all those years? How is it a good way we're going on with manual therapy?
Oh,
in comparison of the past and now.
I have concerns. When manual therapy began in physical therapy, if you go back to the 1960s. With few exceptions, maybe Norway, maybe a little in the Netherlands, and nothing in New Zealand or America, manual therapy started to be introduced by people like Maitland, Carlton-Morn, myself, and there was great excitement because it was the first specialist area being practiced and would lead eventually to a higher measure of autonomy, and it did. And we were the first specialty group within the World Confederation of Physical Therapy, now World Physiotherapy. The people who came to our seminars that we put on were experienced clinicians, and they had very good questions, and they were trying to upgrade their level of skill. Today, manual and manipulative therapy, in the United States at least, is being instructed to students. And they are not particularly experienced, if they even had their hands on a patient, hardly ever. And they're being instructed by faculty who are not clinicians quite often. So the current generation of physical therapists do not have a sound appreciation of the talents and skills that were being delivered some years ago. And I'm afraid the standards are therefore dropping in manual therapy. And a lot of people come into the profession thinking little of it because it wasn't instructed by personalities who knew the field well and could inspire the students to it. And then there's a difference in students today. I don't believe the youth of today are as committed to their professional lives as they used to be.
Is this always be a thing with the 70s as well with the younger generation, or is there a shift going on?
I'm sure my father thought that the generation that I'm a member of was not as good as his generation, so that's a generational thing. But no, I think all the technology today, the way they spend your time on the phone, you see young people going out together, but they talk on their phone to one another. They don't converse. So I think there's a difference today. But we used to apply ourselves to the profession with a lot more dedication than I'm seeing today in the new graduates coming out of school.
Sandra, do you want to give an add-on as a question for this one?
Yes. I totally agree on that. On the other hand, there are other skills that they are now going into. It's more patient-centered care. What do you think about this movement of going more involved or more research in patient-centered care in manual palliative?
Some of the technologies, some of the terminologies that people are using are like patient-centered care. I don't remember when I didn't focus my care on the patient. I know it's a new term, but I don't think it should be a new practice. I think we've always done that. The patient always came first. What I'm hearing a little bit of is not enough about the examination of the patient should determine how you define the care you're going to give the patient. I don't see enough emphasis on that. It's patient-centered care, or it's this way or that way. But it begins with the patient evaluation. And of course, yes, you listen to the patient, and there's pain management techniques. But we go through fads, like we were talking about clinical prediction rules. Well, they're gone now, almost pretty well. And so along will come the next fad. I've never followed fads. My approach to manual and manipulative therapy is to practice an amalgam, an eclectic approach. I don't ever have understood how someone can do it just Maitland way, or just McKenzie, or just Carlton-Born, or just the pain science. You've got to have all those skills and talents. We are all musculoskeletal therapists, and we practice musculoskeletal. Manual therapy is a significant portion of that, and but you don't practice it alone. You need the other talents and skills.
If we get back to the past, IFOMPT is now 50 years.
Yep, 50
old.
years old.
During the 70s, what was the main role of the manual therapist back then?
Well, back in the beginning, our main role was to get it accepted in each nation.
Recognized.
Well, when we started in the 60s, it was only being practiced, say, in maybe Scandinavia a little bit, and a wee bit in Australia by Maitland and a small group there, and same in New Zealand a little. But in founding IFOMPT, we communicated with each country. That was my role as chairman, to communicate with every country of WCPT and to encourage them to form groups. So when we got to Montreal, we had 12 countries present, and 10 of those countries met the initial standard for becoming a member of IFOMPT. And since that now we're at 26 countries, well, I think something like another 18 or 19 in the wings waiting to join IFOMPT.
And how was it back then? Was it like sharing knowledge with each other, or just forming groups for getting recognition?
It was about two things. One of the big discussions at the founding of IFOMPT is, should we be an organization based on having qualified standards? So you have to reach standards to become a member. And I personally was against that. I was more for it being an organization where people could come together and share ideas and concepts and papers.
Just like networking
like
with
most,
each other.
Yeah, and most organizations.
All right.
But standards, the discussion on that won out, and that's what we're based on standards. And I think it's been quite effective, I have to agree. But I could never see how we could get together the people like Maitland on one hand and Carlton-Born on the other, such disparate practices. I feared that trying to bring them together in standards would not work. But then in the person of Gregory Grieve, who was trained as a teacher, he understood educational structure and managed to bring that together in the Standards Committee. So it worked out.
So it's like there are different kinds of things with Maitland and Grieve, and it's like, what are the strong points from the Grieve and Maitland as well?
Yeah.
And integrating them within IFOMPT.
Well, developing a framework that would allow for everything.
Yeah.
And that's what we achieved.
To get more efficiently as well.
I was concerned they wouldn't be able to manage it, and it might break up an organization that was just starting.
Interesting
but
to
I'm
hear.
very pleased to see that they managed it. I'm in full support of the standards.
Okay, all right.
I don't want to see them weakened.
Yeah. And now we're cycling to the 80s. That was my decade of birth, so
right.
87. But so how was the 80s within IFOMPT? And
80s and IFOMPT. Well, I was 16 years on the executive, it turns out. I think the 80s were fine. Initially, we didn't know how important we were. In other words, We had an organization and we ran it and we met every 4 years. But some countries, and Netherlands was one of them, it was very important to become a recognized member of IFOMPT. I think, if I'm not mistaken, you even got paid more if you had that status. So that meant something to you that most countries, it didn't mean anything to at all in that sense. So you people in the Netherlands had internal struggles to come together to form one organization. I was part of helping to have that created. It was under the presidency of Robert Sydenham of Canada. We actually met in Hong Kong with some of your principals to sort out matters, and you became unified, and I think that worked out. So there were a lot of political battles on the different schools of thought, and that was my main concern from the start, that would be possibly a downfall of IFOMPT. But we've managed, and I think it's to our credit that there is only one member organization from each country. There is a slight division in Australia currently. You might have seen 2 flags at the opening ceremony from Australia, and that's because of a division that they need to settle.
Yeah, makes sense. Sandra?
Yeah, we're so happy in the Netherlands that we have one organization, of course, and we see a differentiation between educations, but we are actually happy on it. That we are not, because they learn from each other, they work together, the teachers, and learn
Good.
from each other and give each other feedback on graduate assignments, etc. Could I go back to your point that you say that there's a kind of criteria before you can start a study? Would you then recommend to have some years experience before you, as a physical therapist, before you start your study of manual therapy?
I don't know what your situation in the Netherlands is, but now it's mandated in the United States that every student in their training receives manual and manipulative therapy training on the spine and extremities, including thrust techniques on the spine, which I'm totally opposed to. Because in the earlier days, we gave a series of courses and then written oral and practical exams. Then we taught thrust techniques. But by that time, the people who got through this whole pyramid of education, it was a small number. So those who got to the post-exam stage and learnt thrust techniques, they were skilled at them. And I think it was a very good system. Now everyone learns it. And it's just like massage. Students don't appreciate the value of massage because it's done by everybody. And so we have now dumbed down manual therapy to that level. And many of our publications also are at a low level, in my opinion. When I see a paper saying that for treating cervical pain, you can manipulate the thoracic spine, any level, either side, as often as you like. Okay, it may have a positive effect psychologically, neurophysiologically on the cervical spine. But surely that's not the preferred way to go. Whereas the examination determines what's wrong in the cervical spine and address that. No, they're just out for the effect of manipulation. You may as well take medicine or a stiff shot of alcohol.
So
you're not treating the cause. The effect will not perhaps last as long as it should if you don't examine correctly and treat the cause. There's too much emphasis on manipulation, not enough on examination.
So that one is key for you, the
I think
examination
for me,
one.
yes, very key. Yeah.
Is that something we need to take care even more in this decade?
Well, we focus on the history now of the patient, or listening to the patient and their pain. But I still think the physical examination, I would say, it's being neglected. I always said that the physical examination is more important than the manipulative. You can manipulate, fine, but if you don't know how to examine the patient, your manipulative skills are wasted, mostly wasted.
Yeah. Well, what's the position of the using your hands-on technique as a manual therapist?
What's my position?
Yeah, well, what's your point of view on that one?
Oh, I'm
using the hands-on techniques.
Well, I tend to be mechanistic. I mean, when I look at Maitland's techniques, he didn't mobilize along joint lines. He oscillated vertebra for the effect of pain and the symptoms that the patient was having. I would turn those same techniques around, and I did use oscillations, and put them along mechanical lines so that they actually produce glide. So I tend to be osteopathic in approach to what I was doing, but I use everything. I use Mackenzie, Mulligan's techniques. But listen, I'm 20 years since I treated patients. To the audience listening to this, I'm 87 years of age next month. And I retired at about 67. Is that too soon? Now, I've been involved in higher education. I was president of a university after that. But I'm talking from my memory, and it may not be as articulate as I'd like it to be.
Yeah, for example, in Holland you've got Aad van der El. You know that one?
Yeah, no, what's that again?
Aad van der El.
Oh yes, I know the name.
Yeah,
yes.
with the techniques going
Yes,
on.
yes.
Old pictures as well. I think 70 or 80s.
Wasn't he left-handed, right-handed? Wasn't that all that system? I could never understand it. If that's the gentleman you're talking about.
Yeah, but no, that's something else. Left-handed, right-handed.
Yeah.
Yeah, that's another.
It's another group.
The Marsman thought, I think.
Yeah.
Yeah. You mean left-handed, right-handed? That there's a kind of clinical rule if you have a rotation on the lumbar spine to the right, then it will
not that.
Automatically.
No. It was a gentleman in your country. You might want to edit this out. There's a gentleman in your country who determined
to inform you about further program
much of the examination of the patient based on whether you were right-handed or left-handed.
45, we will have a product
and that's the way you
from
should sleep and do all other kinds of activities.
Also
and I listened to that gentleman, but I could never understand it.
Yeah, because the reason I was talking about Aad van der El, that was just like Greece, with a handbook as well, with techniques described and answers on it.
Right.
There's a lot of ways of using the techniques in different direction and everything else. And the year I was graduated with manual therapy as well, a lot of them, like 90 or 80% was vanished.
Right.
So you're reading the textbook and you're thinking, this is something else in the past and now.
Right.
So what's your point of view with this development of reduction in using hands-on techniques as well?
Well, I'm very much in hands-on techniques. I'm not sure I get your question.
Yes, so, if you look at the education rise with the past and now,
would be for restrictions.
Yeah, some techniques are not being educated anymore.
All right.
For some reasons. But
well, my techniques were mainly based in the acute phase. I might do oscillations to try and abate pain using neurophysiological principles.
Yeah.
But I mainly looked for joint restrictions. And so if I found a restriction and I wanted to mobilize a certain joint in the spine, I would then have to think about the joint above which might be compensating. So I would use either ligamentous tension locking system or a facet locking system so that most of my forces would be directed at the stiff joint. And that's what I would mobilize, and in the direction of its restriction. So it was specific with active movement testing followed by passive movement testing, select the level, the joint, and then manipulate accordingly. That's how I treated pain, not with heat or ice, although I often used heat to relax the patient just for a while, so it made it easier for me to manipulate with less force. If the patient was relaxed and had been lying down for a few minutes with a hot pack, that's fine by me. I don't think the hot pack had any therapeutic advantage other than physiologically make the patient rested and more compliant to the manual therapy. And I think that's neglected today as part of the approach.
You did say earlier about the diagnostics, which are key for the manual therapist to start.
Right.
How did you integrate that one with your therapeutic interventions within the diagnostic one?
If you look at it, if you look at the spine again, you'd have a person like Maitland who would never tell you what the diagnosis was. He was treating the pain. But then you had someone like Syriax who said it was all the disc. And it was either a tear of the annulus, which you would manipulate, or a prolapse, which you would give traction to. And then along came people like Stoddard, the osteopath physician. He was into the facet joint and also sacroiliac. He added that to the possibilities. This is the 1960s when, the first disc surgery, first time a disc was operated on was 1934. Before that, no one had any idea what might be a major cause of back pain. If you had a neuropathy, drop foot, it was thought from a spinal tumor. They thought the disc prolapse was a tumor. Then they found out it was a nucleus. So, it's only recently that we moved away from just the disc to thinking about the facet joints, to the sacroiliac. And then you had Kaltenborn, who didn't try to differentiate too much of those things, but just go for movement. Again, not convex concave on the extremities, but just manipulating, mobilizing, same thing, on the spine to regain function. So my approach is a kind of a combination of all of that. I think they're all right at certain times, more so than others, and I practice on that basis.
Sandra?
Yeah, so you actually say that the manual therapist should be having a lot of skills, a lot of knowledge and a lot of skills, and combine them, and having a kind of clinical reasoning that he can combine. That's pretty complex.
Clinical reasoning based on a thorough examination and listening to the patient and things like that, yes.
Yeah. And this complexity, on the other side, you say the students are not as motivated as before, perhaps?
I think so.
On the
They're
other hand,
more interested in their lifestyle, and they work to earn an income so they can enjoy life. I think my enjoyment was in my profession. I was totally dedicated to it, and my life sometimes had to take a second place. And I think that's the way it was with my generation. We all wanted to get ahead, you know.
But I see also students who are very dedicated.
Good.
And also going into research more than into practical things.
That's unfortunate.
Yeah, it's unfortunate.
Well, we need some people in research. Maybe we need fewer with more support. If we have too many researchers, we won't have enough funds for any of them to do any good research.
Good point.
Yeah, that one is interesting. I talked a couple of years ago with Raymond Osterlo from the Vrije University of Amsterdam.
Right.
He's a professor and was before physiotherapist as well. He was talking about the amount of people doing physiotherapy or manual therapy and how many percentage should do scientific research. So it was like, I think 5% or till 10%. And if you shifting that one, that's not good for the working field as well. So there's always a good combination with putting up with scientific research.
I'm certainly interested in research, although I'm not current in it. I don't read it now because I'm not practicing, so I listen to it like here in these meetings. But I'm on the Foundation for Physical Therapy Research in the United States, and I've contributed, my family has, considerably to research. I think we have enough researchers. We just need to fund them better. And I would trust that more researchers spend some years in the clinic. A lot of people get into teaching and or research because they don't enjoy the clinic. And that's unfortunate. Because if they can't hack it in the clinic, what kind of a teacher or a researcher will they be? So those are safer careers. They're quieter careers with less criticism, more security than in private practice in physical therapy. You've got to be good to survive in private practice in physical therapy.
It should be step one for everybody within our field.
And I think before you go to get your PhD, you should have several years in clinical practice. I didn't get my PhD in neuroanatomy until I was 45, and I'm pleased I left it to that long because it gave me a new lease on life, and I could take really meaningful experiences into my research, and it answered a number of questions that I was engaged in. But you go straight through school, have a few months in the clinic, and then go to do a PhD, not the right way. Even if you're pretty brilliant, still not the right way, in my view. Spend some time in the clinic. Research what it is you know about.
That's a good one to hear. We're going to the end of the podcast. I want to give Sandra one final question to give to you, Stanley, and then after it we're doing the take-home message you can give to the listeners. But before Sandra, please.
I have two questions. Is that also possible, Melvin? Two questions.
That's okay.
First question: which topic should be researched then? What's your priority in research?
Well, it would be nice to know a bit more about the mechanisms of how manual therapy works, but I think we've got enough on that. I frankly think we've got enough research. It proves, if you at this last session we just finished, where Chad Cook was speaking, we got meta-analysis after meta-analysis, hundreds of articles, if not thousands, that prove the effectiveness of manual and manipulative therapy. We're coming to an age of precision medicine, where by knowing more about your blood type and things like that, the cancer treatment can be selected right to you, to your particular cancer, and it's proving to be very effective based on your genome type and all of that. I'm not very familiar with the details, but we're coming to precision medicine. If we could get closer to precision physical therapy by research, knowing exactly which patients will benefit from manual and manipulative inside the framework of musculoskeletal, or others that really need just pain science or just need exercises, that would be helpful. But I think the clinician, if well balanced and eclectic, may waste a treatment or two, but will soon find the right approach for every patient that they see.
You've got another one?
Oh, the other one is, do you have tips for the future, or is it the same that you want to ask?
Well, I would say, and we're going to hear more about it today, and I'm interested in listening to it, and it was part of my Maitland Award address the other night. I finished up saying a few words about artificial intelligence, because I can see the day where a robot or some other device will be able to examine many of our patients, has the latest literature in their head or in their computer system, and can give the patient the best advice, monitor them 24/7, giving advice, encouragement, and everything else far better than the average physical therapist. And therefore, if you don't have something special in the way of patient communications, a therapeutic presence, if you're not a skilled clinician with hands-on skills like manual therapy, then you might be replaced by artificial intelligence.
It's a beautiful ending with the answer, Stanley. Do you want to give another take-home message as well for the listeners?
No, I think that will be it.
That was a combination. That's very efficiently from you. Thanks a lot for that one.
Well, thank you for the opportunity to speak to my fellow physical therapists in the Netherlands.
Yeah, and we would love to thank you as well as a guest speaker in this podcast from the Dutch Association for Manual Therapy. And I would like to thank my colleague, board member Sandra as well for joining in.
Thank you very much for the opportunity.
Thank you too.
Thank you.
And thanks to IFOMPT as well. Special thanks for giving us the opportunity to record on this location as well. Thanks for listening to this podcast. If you want to know more about IFOMPT, go to the website ifompt.org. If you want to know more about SVOMP, go to swomp.ch. Are you a Dutch colleague and want to know more about the Dutch Association for Manual Therapy? Please visit our website. If you're not a member, become a member. Together we can shape the world of manual therapy. Have a nice day.